There are a lot of new drugs coming on the market. I have to say that some of them will be very important because they set a new standard. In particular, some of them will be used in the so-called triplets, so 3 drugs combination, like for example carfilzomib plus lenalidomide and dexamethasone that has been recently approved also in Italy for people at relapse. And what is even more interesting is a new category of drugs, because carfilzomib or ixazomib are proteasome inhibitors, as was bortezomib, so the first in class. Pomalidomide versus lenalidomide are again in the IMiD category, as was thalidomide, which was the first in class. But now we heard some presentation, and were already presented in other meetings, like the American Society meeting last December, or in June at the European Society of Hematology meeting, of antibodies. For the first time since ever in the last years, we have antibodies to treat multiple myeloma. We basically have 2 that will go to the market in a relatively brief period of time, which are the daratumumab and elotuzumab. Daratumumab is used in combination, but is very effective also as a single agent in patient failing even 3 lines of previous therapy. Elotuzumab is usually employed in combination with the IMiDs and steroids. But what the industry is trying to do now is the combination of 4 drugs, which means to add other antibodies that alone they have really a small activity in multiple myeloma, that are the checkpoint inhibitors antibodies, so the so-called anti-PD-L1 antibodies. Like, there are the 2 most famous because were tested a lot in solid tumors and in Hodgkin disease, are nivolumab and pembrolizumab. And now these antibodies are tested also in multiple myeloma in combination with other drugs. The idea of using checkpoint inhibitors with other drugs that are immunomodulatory, like lenalidomide or pomalidomide, might be interesting, even though we don't know anything about toxicities, because, for example, in a different setting, in indolent lymphomas, checkpoint inhibitors were combined with lenalidomide, and the trial was stopped for toxicity. So sometimes you can envisage a toxicity from a theoretical point of view, but then in the real life practice, you have to discover that toxicity is completely different, and you have to stop the trial, or you have to manage unexpected toxicities. So to conclude, to make a sort of a summary, is a period that lasts probably 12 years, with a lot of drugs, with a lot of achievements in terms of prolonging survival of patients, which is basically the real goal of any study and any new therapy, and also improving the complete remission rate. Though it is frequently said by regulatory authorities that complete remission is a sort of a surrogate endpoint for a clinical trial, I stress the point of complete remission rate in a given trial, because complete remission means that the patient has a fantastic quality of life, has absolutely no symptoms from the disease, so means a normal life. So complete remission is important, and complete remission in all hematological disorders has been correlated with survival. So always when you reach the complete remission, your survival is better. And these new drugs have changed the complete remission rate in young patients, so what we say below 65 years of age, and also in the elderly. I can say that when I was a resident in hematology, not a huge amount of time ago, but some time ago for sure. Median survival of multiple myeloma patient was 3 years. That was altogether young and all the patients. Now we can say that for young patients it's probably more than 8 years, approaching the 9 years, and for the elderly is approaching the 4 to 5 years. So really these new type of drugs combined always with the old ones that have not been discarded or with autologous transplantation are providing really clinical interesting results for our patients. Complete remission means that you cannot see any evidence of disease with the standard examination, let's say blood test, imaging, or histology of the bone marrow. Molecular remission means that with more sophisticated technologies like PCR, you generate a specific marker for the patient that in multiple myeloma is based on immunoglobulin genes, and in lymphoma or leukemia is based on a translocation or other fusion genes. And you go to detect the presence in a normal bone marrow of a molecular amount of disease. And in all hematological disorders, and we have demonstrated several years ago also in multiple myeloma and in lymphoma patients, that molecular remission correlates with survival and correlates in lymphoma and leukemia with the cure rate. Nobody knows if it correlates with the cure rate in multiple myeloma because there were not enough strong drugs at that time to induce a lot of molecular remission, that actually molecular remission was present only in patients receiving allogeneic transplantation, while in leukemia is absolutely more common. No, there are particular infusion toxicities, so infusion reactions, anemia is important, but at the end is something that you can manage and is so active. It's always a balance. If a drug is giving some toxicity that you can manage obviously with no particular real harm for the patient, okay, you are keen that you say, okay, I go on because it's so active that it's prolonging my survival. I don't care if I have to make some premedication before infusion, or even if the infusion is weekly at the beginning, and so it's for sure not something comfortable for the patient. But if something is very active and is getting rid of your bad symptoms of disease, you say, okay, I do it. Is changing, and that's absolutely a personal opinion. We do not have enough data coming from the trial, but my feeling is that the combination of daratumumab with other drugs will push forward again the percentage of complete remission rate, overall response rate, and will increase the survival length. Is not yet approved. In Italy now we have a compassionate use, so the named patient program, so patient can have access to it through that, but it's not approved yet. And the named patient program is daratumumab single agent, but now daratumumab is studied also in combination with a lot of other drugs, with Velcade and dexamethasone, for example, which is a trial. There will be an update this year at the American Society meeting in December in San Diego, and Velcade is already available on the market, so it's not difficult to combine one new drug with others already present on the market and available.